Hello everyone, welcome back to this series of lectures in hepatology. Today we will be learning about alcoholic liver disease. So let's begin. So what is alcoholic liver disease? As the name suggests, alcoholic liver disease is basically a disorder which occurs due to chronic alcohol consumption. Right? So chronic alcohol consumption is basically toxic to the liver. So chronic alcohol consumption results in a group of disorders which affect the liver, which is called as this alcoholic liver disease. Okay. So what are the risk factors for the development of alcoholic liver disease? So it depends upon the alcohol dose. So if the dose of alcohol that they consume is more than 1 drink per day in women and more than 2 drinks per day in men. So the permitted level of alcohol consumption is 1 drink per day in women and 2 drinks per day in men. And if it goes beyond that, and if the process has been continuing for more than 5 years, then you can definitely have an alcoholic liver disease. So if this process has been continuing for more than 5 years, you can definitely have an alcoholic liver disease. Then it depends upon the drinking pattern. So binge drinking means continuous drinking maybe for about 2 hours to 4 hours, right? And then there has been a gap of where they have not consumed alcohol, and within this short span of time they take a huge amount of alcohol. So binge drinking itself, and if the pattern goes on for a long time, there is a risk of alcoholic liver disease. Then genetic patterns or genetic factors such as PNPLA3 polymorphisms. We had seen this in our chapter on metabolic dysfunction associated liver disease, where there is a genetic polymorphism in your lipid transport protein. So this is basically associated with lipid transport. If there is a defect, that means that they already have a predisposition to lipid accumulation in the liver, and when you add alcohol to it, this can further worsen the damage. Then smoking, increased BMI. So all of these are very, very important risk factors for alcoholic liver disease. Most importantly is the amount of alcohol and your pattern of drinking. Okay. Now let us understand the pathogenesis of alcoholic liver disease. So first thing is that there is ethanol, right? So alcohol is nothing but ethanol. Now ethanol is something that can be easily absorbed. So it gets easily absorbed from the stomach and it is metabolized in the liver. So the site of metabolism of this ethanol is in the liver. That is the reason why excess alcohol consumption first damages the liver. So ethanol is acted upon by this enzyme which is called as alcohol dehydrogenase, and this is then converted into aldehyde. Okay. So ethanol is acted upon by the enzyme alcohol dehydrogenase and it is converted into aldehyde. Now acetaldehyde is converted into acetate. What type of aldehyde? It is acetaldehyde. Acetaldehyde is converted into acetate by another enzyme which is your aldehyde dehydrogenase. So acetaldehyde is converted into acetate by another enzyme which is your aldehyde dehydrogenase. Okay. Now this acetate is broken down into coenzyme A, and the coenzyme A is converted into fatty acid which accumulates in the liver. Now acetate is converted into coenzyme A, which is converted into fatty acid and it accumulates in the liver. Now this alcohol dehydrogenase in itself, when it acts, lot of reactive oxygen species are produced as a result, and it can also result in damage to the liver. So one is alcohol is converted to aldehyde, converted to acetate, acetate coenzyme A is converted into fat which gets accumulated in the liver. So this will lead to steatosis again. So initially there is steatosis, then there is steatohepatitis, and finally there will be cirrhosis. Also alcohol dehydrogenase, when it acts, there are a lot of reactive oxygen species which are produced, and these reactive oxygen species also damage the liver. In people where sometimes there can be aldehyde dehydrogenase deficiency, there will be accumulation of acetaldehyde, which is a toxic product, and this can result in recurrent flushing. Okay. So this is about your metabolism of ethanol. Also, what happens is that ethanol also causes an increase in the ratio of reduced to oxidized NAD. NAD is an enzyme, so which stands for nicotinamide dinucleotide. So there is an increase in the ratio of reduced to oxidized NAD. So what happens is that this reduces the mitochondrial oxidation and this further worsens the damage in your liver. So this is about the entire pathogenesis, about how ethanol acts by different mechanisms, finally causing accumulation of toxic products and damage to the liver. Okay, so this is about the pathogenesis of alcoholic liver disease. Now let us look at the clinical features. Let us look at this clinical features. So this is a very funny looking diagram, but this diagram on the whole will help you remember easily what are your head to toe manifestations of alcoholic disease. Right, so we know that alcohol in such does not affect only the liver, it affects the man from head to toe. So what are all the clinical manifestations of chronic alcohol consumption? And some of these are also stigmata of alcoholic liver disease and chronic liver disease. Okay, so chronic alcohol consumption and alcoholic liver disease can be associated with alopecia. Right, can you see that the person does not have any hair? So there is alopecia. So we'll go from head to toe. Secondly, what is this eyes denoting? The eyes is denoting that it is yellow. So there can be jaundice. There can be jaundice. How is this nose? The nose is like a potato nose. So this is nothing but your rhinophyma. This is your rhinophyma. And as a whole, when you look at the patient, how does he look? He is having a lot of tiredness. There is a lot of lethargy. So there is a lot of tiredness, there is a lot of lethargy and low mood. So there can be a lot of low mood disturbances as well. What are these swellings that you see here? This is nothing but your parotid enlargement. So they can have bilateral parotid enlargement. Okay. Then can you see that the patient is very lean? The patient is very emaciated. That is because of loss of muscle mass, and this is what we call as sarcopenia. There is loss of muscle mass, patient is very emaciated, and there is a protein energy malnutrition that can set in with chronic alcohol consumption. Then what are these red spots? What are these red spots? So these are nothing but there is a central feeding arteriole. There is a central feeding arteriole surrounded by capillaries. So there is a central feeding arteriole surrounded by capillaries. Okay, so there is a central feeding arteriole surrounded by capillaries, and this looks like a what? This looks like a spider. So this is what we call as your spider nevi. This is what we call as your spider nevi. And if you take the head of the pin and you press the central arteriole, there can be blanching. There can be blanching, and this is what we call as your spider nevi. And where do you find it? You find it along your SVC territory, which is around your upper neck, chest and back. So spider nevi are a characteristic feature of chronic liver disease. It is a stigmata of chronic liver disease. Okay, fine. Then what else can you find? You can find hepatomegaly. You can find hepatomegaly. Okay, you can find hepatomegaly. Then what are the hands showing? The hands are red in color. So what are you seeing there? You can have palmar erythema. You can have palmar erythema. And this is also a stigmata of chronic liver disease. This is also a stigmata of chronic liver disease, right? So alcoholic liver disease can be associated with a lot of other conditions that we have discussed. There are certain stigmata of chronic liver disease which includes your spider nevi, which includes your palmar erythema. Okay, then as the chronic liver disease progresses, around the umbilicus you can find dilated veins. You can find dilated veins. These are called as caput medusae. Okay, these are called as caput medusae. Apart from that, in the hand, another thing which I forgot to mention is that you can have a contracture. You can have a contracture. So there can be a thickened ligament like thing which can be seen here in the palm, and you can have a contracture where the fingers will be bent. That is your Dupuytren's contracture. This is your Dupuytren's contracture, right? So, when you do a head-to-toe examination and the clinical features of alcoholic liver disease and associations, these are the associations. So, Dupuytren's contracture is also seen associated with alcoholic liver disease. Then, what happens to your testis and what happens to your genital tract? You can have testicular atrophy. You can have testicular atrophy. Fine. Then, what happens to your feet? You can look at here. The feet are very wobbly because you can have a distal form of peripheral neuropathy. It can be a distal form of peripheral neuropathy, and they can be cerebellar hypoplasia with chronic alcohol consumption, which can result in a lot of this wobbling, or they can have gait disturbances because of that. So, this is about your head-to-toe examination of your patient with alcoholic liver disease, and you have to look for stigmata of chronic liver disease as well. And this is what I have written here. So, what are the stigmata of chronic liver disease? It includes spider nevi, it includes palmar erythema, it includes caput medusae, testicular atrophy. So, all of these are stigmata of your alcoholic liver disease. Okay, fine. Now, let us understand what are the laboratory features that you would expect. So, the laboratory features are, let us start with your CBC. So, chronic alcohol consumption can be associated with which nutritional deficiency? There can be B12 deficiency, and this B12 deficiency can result in what? Megaloblastic anemia. There can be a megaloblastic anemia, or in severe forms there can be pancytopenia also. Okay, fine. So, this is about your CBC. In your liver function test, hypoalbuminemia will be present, chronic inflammatory state, hypoalbuminemia. Then there will be TBDB elevation, mild TBDB elevation can be there. There can be profound elevations in a more severe form. AST, ALT will be elevated, and the characteristic enzyme for alcohol consumption is your GGT. GGT will be elevated. What is the pattern of AST-ALT elevation? The AST to ALT ratio will be more than 3. This is what we call as the de-Ritis ratio. So, the ALT will be much lower when compared to the AST, because there will be deficiency of your PLP, or your pyridoxal phosphate enzyme, which is required for the action of ALT. This we have read in our chapter on approach to liver function test. Okay. If there is alcoholic hepatitis has progressed towards your chronic liver disease, then your PT-INR APTT can be elevated, which is suggestive of coagulopathy. So, this can be prolonged, and they can be associated thrombocytopenia, where the platelet counts are also reduced. Okay. So, this is about the various laboratory findings that you can expect in alcoholic liver disease. Now, let us look at the diagnosis. Now, apart from this laboratory findings, we can use the USG or an MRI. In the ultrasound or the MRI, you can show evidence of fatty deposition. So, initially there is a stage of fatty liver, then it progresses to the stage of steatohepatitis, and finally it progresses to the stage of cirrhosis. So, on the ultrasound you can find hepatomegaly, you can find fatty deposition, then there can be steatohepatitis, and in cirrhosis you can find the presence of a shrunken liver with nodules, On histopathological examination, if you do a biopsy, then what happens? You see zone 3 lipid droplets, right? So, you see zone 3, this is your zone 3. So, you find lipid droplet accumulation. Another characteristic feature is the presence of these Maddrey-Denk bodies. Maddrey-Denk bodies are bodies which are characterized by hyaline material, ground glass and hyaline material, hyaline eosinophilic material within the hepatocytes. They can also find ballooning of the hepatocytes. Ballooning of the hepatocytes and Maddrey-Denk bodies are some features you can find on your biopsy of alcoholic. Then fibroscan. We have learnt about fibroscan in our chapter on MASLD. So, fibroscan is basically what we call as elastography. This is a non-invasive method of identifying the stage of fibrosis, So, when you do a fibroscan, you basically determine what? You determine the liver stiffness. It is used to find out the stage of fibrosis or liver stiffness. So, if the liver stiffness is given in terms of kilopascals, if it is less than 8, well and good. More than 8 kilopascals is advanced fibrosis, more than 12 kilopascals is cirrhosis. This is a non-invasive method which is used to find out the stage of fibrosis in your alcoholic liver disease. Okay. So, what are the tests that you do? You look at your entire blood picture, then you can do an ultrasound. If fibroscan is available, do a fibroscan to see. So, it helps in early detection of cirrhosis to see which stage of fibrosis they are on. Invasive method would be your biopsy. Okay, clear till here. Now, let us go on to the management. So, the short-term mortality is basically determined with the help of 3 scores. So, there are 3 scores which you should be knowing. Okay, so the first is your MDF, which is your Maddrey Discriminant Function. Okay, MDF. So, what is it given by? It is given by this formula 4.6 into actual minus the normal prothrombin time. So, we know that in alcoholic liver disease, you can have prolongation of the prothrombin time. So, what prothrombin time of the patient minus the actual normal prothrombin time plus serum bilirubin in milligram per deciliter into 4.6 gives us the Maddrey's discriminant function. Okay, this gives us the Maddrey's discriminant function. And if this value is more than 32, that means that this is a severe alcoholic liver disease. If this value is more than 32, it means that it is a severe alcoholic liver disease. The next score is your MELD score. Okay, the latest score is a MELD 3.0, which was devised in 2023. Okay, so the MELD stands for Model for End Stage Liver Disease. Model for End Stage Liver Disease. So, what are the components of MELD score? It is INR, total bilirubin, serum creatinine, sodium, albumin and the gender. So, you do not have to know the formula. All you have to know is that the MELD score can be used to prognosticate and to identify the severity of alcoholic liver disease. So, the MELD score can be used to prognosticate and identify the severity of alcoholic liver disease. So, whenever a patient presents to you with alcoholic liver disease, put in these parameters into the calculator of the MELD score, which is available online, and find out the MELD score. So, what they might test you is the components of the MELD score, which is very important. So, if this is more than 20, then this also means that this is a severe alcoholic liver disease. Then, we use another score which is called as your Lilly score. So, the Lilly score is basically used for prognostication and to assess the response to treatment. Okay, so this is used for prognostication and is used for assessing the response to treatment. So, what do we do here is that we check the bilirubin on day 0 and day 7. Then you take albumin, you take the age and the prothrombin time. How do you calculate? It is not important. How do you apply this Lilly score? We will be seeing now. Now, let us look at the flow chart or your approach to the management of alcoholic liver disease. So, when do you call it a moderate disease? Just now we have discussed if the Maddrey's discriminant function is less than 32 or the MELD score is less than 20, then this is a moderate alcoholic liver disease. So, you definitely have to counsel the patient, you counsel them for de-addiction, you do a lot of lifestyle changes, ensure that he stops drinking alcohol. Because if the patient is in the stage of steatosis or steatohepatitis, then it is still in the reversible stage. Okay. If this is a severe alcoholic liver disease, that means that the Maddrey's discriminant fraction is more than 32 or the MELD score is more than 20. Then what you have to do is you start the patient on steroids. You start the patient on steroids, which is prednisolone at 40 mg per day dose. Okay. So, steroids are used in the management of severe alcoholic liver disease. You start them at prednisolone at 40 mg per day. Okay. And you continue that for about a week. Okay. So, after that what we do is we calculate the Lilly score. If the Lilly score is less than 0.45, then you continue your steroids. You continue your steroids for 28 days and then you taper and stop. That means that the patient is having some response to steroids, so well and good, continue and taper it over 1 month. But if the Lilly score continues to be more than 0.45, that means that there is no response to steroids. There is no response to steroids. So, it is better to stop the steroid treatment and refer for liver transplant. LT is liver transplant. Similarly, you also have to be aware that you have to know the contraindications for your steroids. So, what are your contraindications to steroids? If the patient is having sepsis, AKI, upper GI bleed, if there is a concomitant drug-induced liver injury, DILI is drug-induced liver injury, presence of hepatocellular carcinoma or HIV infection, then directly put them in for liver transplant. You cannot give a trial of steroids. Okay, clear? So, this is how we manage your alcoholic liver disease. So, in the next session, we will be discussing about chronic liver disease. Thank you.